Hello viewers, you're most welcome to our YouTube channel, The Fertility Hub. My name is Kanyas Jepresi and I'm the founder of Unity Blossom Together Foundation, a foundation that supports women and men that are battling with infertility. Today we are talking about infertility and we have our visitor with us who is going to tell us more about infertility. Most people don't seem to understand what infertility is and all the stigma that is associated with it. So today we have our beloved guest who is going to tell us more about infertility. Yeah, so you're most welcome, Doctor.
Thank you, Prosi, for inviting me. Dr. Muhumza Joseph. I'm an obstetrician and gynecologist. I'm a fertility specialist and also an MIS surgeon. I'm glad to be here.
You're most welcome and we are glad to have you here.
Thank you.
Dr. Muhumza, can you briefly tell us about infertility? What is infertility? We seem not to understand what infertility is. Most people see it differently. So we'd like to understand what infertility is.
Okay. So to understand infertility, we need to first understand what it means to be fertile. So to be fertile is the ability to reproduce. So infertility, by definition, is failure of a couple to achieve a pregnancy after 1 year of regular, unprotected, and penetrative sexual intercourse. We take 1 year if the woman is below 35 years. But if the woman is above 35 years, we say it is 6 months. 6 months of regular penetrative sexual intercourse without achieving a pregnancy, that is infertility.
Okay. So
we classify infertility into two types. We have what we call primary infertility and secondary infertility. Primary infertility, basically this is where you find the couple has never achieved any pregnancy. However, with secondary infertility, we find that the couple has previously achieved pregnancies, but they are finding it hard to conceive subsequent pregnancies.
Okay.
So that's how we define infertility.
Okay. When you talk about regular intercourse, do you mean daily or how regular is regular?
So regular intercourse, we are talking about 3 to 4 times a week.
Okay.
Yes, and this intercourse has to be penetrative.
Okay.
Yes.
So if someone has spent 1 year with when they're having the regular intercourse, that means after 1 year they've failed to conceive, they are classified as infertility.
Yes.
Infertile.
Infertile. Yes.
Okay. And does the infertility affect both men and women? Because we have had most families out there, they will think it is a woman's, it's a woman who is failing actually to conceive. They always, they always look at a woman and not a man. So do also men get infertile, or it is always a woman who is infertile?
So infertility is not basically a woman's problem. Actually, when you get to analyze among all the causes of infertility, you'll find that the women account for 35% of the causes of infertility. The men on the other side account for an equal share. They also account for 35% of the causes of infertility. Then 20% of the couples, you'll find that the cause is both on the woman and the man. And then we have the other 10%, what we call the unexplained infertility.
Okay.
This is a couple whom you've fully investigated. All the results seem to be very okay, but for some reason, they still can't conceive. So infertility is not a woman's problem. The men take actually an equal share of the causes.
Okay.
Yes.
So everyone takes an equal share.
Yes.
I hope people will understand that.
Yes.
And most time in families, I've experienced families, seen people where a woman is actually in distress that she cannot conceive. It is actually not her problem. It is a man's problem.
Yes.
Maybe can you tell us about what causes the infertility? Because does someone wake up and they're just infertile? Yeah.
So for us to understand what basically causes the infertility, we need to understand these 4 steps. Okay. So for us to be able to achieve a pregnancy, all these 4 steps have to be intact. Should there be any disturbance along these steps, then the couple is going to struggle. So the first one, we need a woman to ovulate. We need her to release a mature egg. That's the first one. The second part, we need this egg to be picked up by the tube and transported to wait for the sperm for fertilization. So the tube has to play its role. The third one, we need the man to produce enough sperms that are normal and moving. And then we need the fourth one is we need transportation of these sperms all the way from where they are deposited to the tube for fertilization. So should there be any disturbance along those lines, then the couple is going to struggle.
Okay.
Yes. And we further go ahead and classify the causes because, like I've said, the male take 35%, the female take 35%. The female causes can range. We normally classify them according to their location. So the first one, it could be ovulatory factors, where you find the woman is not ovulating. Maybe it could be advanced age, the eggs have run out, or she has conditions. The common one is polycystic ovarian syndrome.
Does someone actually run out of ovaries?
Yes,
Eggs?
someone runs out of ovaries. What we know is that a woman is basically a time clock. By the time you're born, you have about 1 to 2 million eggs. Okay. By the time you hit puberty, these eggs have come down to about 400,000 to 500,000. And then each month you're going to recruit. So by the time you're in your 45 years, usually the ovarian reserve has come down. But it's also notable to note that women are born with different reserves. Some are born with so much that they will not find it a problem to conceive even at 45 years.
Okay.
Others are born with what is normal, and others are born with little, to the extent that by 32 years, someone is struggling to conceive because the eggs have run out.
Okay.
Something we call primary ovarian insufficiency. Yes.
Okay. So yeah, you were still telling us about the causes of infertility.
Yes.
Yeah.
So that's basically with the ovaries, the woman's ovaries. And then when we move from that, we go to the tubes. The tubes play an important role. These tubes have to be open, but we have conditions where you find that the tubes are blocked. Okay. The most common causes of tubal blockages are infections.
Okay.
Recurrent infections, recurrent pelvic inflammatory diseases, notably those that are caused by gonorrhea or chlamydia. Those tend to block tubes. And also in areas where actually tuberculosis is endemic, places like India, you find that tuberculosis is a very big cause of tubal blockages. Okay? Or maybe you find that someone has undergone a previous surgery. Maybe she had fibroids, they were removed, and then she has healed with scarring, and the tubes have been caught up in the mix. They get blocked. There is also the unfortunate women with endometriosis. Endometriosis is where you find that the inner lining of the uterus develops actually outside the uterus.
So the uterus is upside, it's inside out.
You can say inside out, But the uterus has basically 3 layers. We have the outer layer, and then we have the middle layer, what we call the myometrium, which is the muscle. And then we have that inner layer, the endometrium. So the endometrium is what you shed out every month. Now that endometrium is only and only supposed to be located in that inner part. It shouldn't be anywhere else in the body. But you find that some women, for some reason, that endometrium is located on the outside.
Does such a person experience their monthly periods?
Yes, they do experience their monthly periods, but usually their periods are a little bit different.
Okay.
Most of the time they are characterized by severe pain during periods.
Okay.
Severe pain that sometimes even needs hospitalization. Yeah. So not all menstrual cramps are normal. If the pain is too much that you need constant medication or you need admission during your periods, it could be endometriosis. So someone has to evaluate for that.
Okay.
Yeah. So all that can cause tubal blockages.
Okay.
Yes. So if we move from the tubes, then we go to the uterus. There are so many things that can happen with the uterus. Maybe someone has fibroids, and these fibroids are significant, and they have distorted the uterus, and the tubes are blocked.
What causes the fibroids? I've seen some videos, different videos, where they remove like a huge thing, and they said this was a fibroid. It is even like bigger than a baby.
Yes.
What causes such things?
So fibroids, basically what we know is we know a number of risk factors to getting these fibroids. What we know is that the black population is 2 to 3 times much more at risk of getting fibroids than the white population. Okay?
Yeah.
So us being black, that is our first #1 risk. Okay? The other risk is the age at which you have your first period, the age at which you have your first pregnancy also. We see that women who have taken long without achieving their first pregnancy are at a much increased risk of fibroids. Okay? Initially, we used to see fibroids in old women, 40, 42. But these days, we are seeing fibroids in a much younger population.
What has gone wrong?
Even 26 years, 24 years, you see significant fibroids. So definitely a change in lifestyle has come in, and it affects that. Yes. Okay. But notably, not all fibroids may need interventions. It's only the significant ones that we need intervention.
Okay.
Yeah. Okay. Then we have also the women who are unfortunate that they are born with abnormal uteruses. Okay. One is you find that maybe someone has a double uterus. They have 2 uteruses.
Okay.
One on this side and one on the other side. Or that uterus may come also with another cervix. So 2 separate uteruses. Okay. The others you find they have a septum within their uterus. It kind of divides it into 2. Something called the archway uterus or biconway uterus. So these people will also find it very hard to conceive. Okay. Then from the uterus we move to the cervix.
So doctor, if I can interrupt you there about the uteruses. Do these uteruses actually both grow or they keep at the same stage?
The other one remains redundant. We've had very few cases of that. The only risk is that the horns are usually much smaller compared to if the uterus was one. So usually the risk there is having a miscarriage. You conceive but then have a miscarriage. So these are called Mullerian abnormalities. Someone is born with that abnormality. Then some women are also born with a very small uterus, something called the hypoplastic uterus. It cannot carry a pregnancy. Okay? All these are congenital abnormalities. You're basically born with it. Yes.
Because I've interacted with someone who says they've gone to hospitals, different hospitals, and they were told their uterus is for a 7-year-old.
Yes.
This is someone who is about 40 years, but they told them she I think she went into her period when she was 18, and for her lifetime she has gone into her period only 3 times.
Yes.
And then after it stopped there, gone to different hospitals, gone to different, like even traveled to India, wherever, and they told her she cannot conceive.
Yes.
Yeah.
So it is something called a hypoplastic uterus. For some reason, the uterus doesn't grow to its expected size.
It just keeps the same.
Yes, and most of the time, that is also associated with ovarian problems. Most of the time, those individuals, when you screen them, you find that their ovarian reserve is very low. It is for a woman who is already in menopause. So, because also menopause actually shrinks the uterus shrinks in size. But you find this is a young woman, she's far off menopause, but her uterus is tiny. Very common condition. So it can't carry a baby. That person is only left with an option of surrogacy. Yes.
So actually they can retrieve some of her eggs?
Yes.
Okay.
And someone carries the
Carries
pregnancy.
for them.
Yeah.
Okay. That's, at least there is hope there.
There is hope on
there
that
is
side.
hope.
Yes, there is
you know,
hope on that
sometimes
side.
you lose all the hope and
Yeah.
you're like, how will I, live without my own child?
Yes.
And there are so many there are most women outside there who want babies and they can't carry their own children. Yeah, but when they tell you this uterus is small, it is small here and all that, sometimes you may find someone who doesn't give even a solution.
Yeah, sure.
Yeah, and there are people who don't understand surrogacy.
Yeah, they are. Sure.
Yes. Do you have surrogacy in Uganda?
Yes, we have surrogacy going on. We have gestational surrogacy going on. So this is where someone lends a couple their womb. Maybe this couple has had maybe her uterus removed for some reason. Maybe she had big fibroids or bad adenomyosis. Or maybe she had a bad delivery and bled and she had her uterus removed. But she still desires to have a child.
Okay.
So, or she has a medical condition that doesn't allow her to carry a pregnancy. So we can get someone's womb. This couple can give us the gametes, the sperm and the egg. We fertilize, put the baby in someone's womb. This baby is going to grow. The baby is genetically not connected to the surrogate at all.
Okay.
The baby is connected to the parents.
The father and the mother.
Yes, yeah.
Okay.
So a couple of contracts are signed and then the surrogacy goes on. It's happening. We have it in the country.
Okay.
Yes.
That's at least that's hope. That's
Yes.
hope. The country's hope.
Yes,
Everywhere.
Yes.
Yeah. Thank you so much. Moving on.
So moving on, we are now moving on to the cervix. So what's the role of the cervix in reproduction? The role of the cervix is basically to allow sperms to move from the vagina, move through the cervix up to the uterus. So for some reason, you may find the cervix is closed, what we call cervical stenosis. Okay. In that case, the sperms have nowhere to pass. Okay. Or in some cases, you may find it absent, also a congenital anomaly. Okay. Now, the other thing is this cervix produces some mucus. Okay. This mucus, its role is usually to allow sperms to go through it. Okay. But there are a few individuals where you find that the mucus from the woman's cervix actually kills the man's sperms. The man's sperms cannot go beyond it.
Okay.
So that's going to make it very hard to conceive. So that's also a factor. Okay. Then from the cervix, the next part is the vagina. There are also vaginal factors that stop couples from conceiving. Remember, we've said that this sex has to be penetrative.
Yes.
So there are couples where you find penetrative sex is difficult. Something called vaginismus. Okay. Vaginismus, where you find that when the act starts, a woman's pelvic muscles go into spasms and close off. So the man cannot penetrate. So there's no way sperms will get deposited. Okay? Or there are women still in their adult age. They still have an intact hymen, something called an annular hymen, that a man cannot penetrate. Or the vagina may have a septum in the middle that a man cannot penetrate. So all those factors on a woman can cause infertility. So we start with the tubal factors, we go to ovarian factors, uterine factors, cervical, and vaginal factors.
Okay.
That's how we classify them.
Okay.
Yes.
I hope everyone has understood. Though there are some terms that I seem not to understand. Is there any way infertility can be addressed? So that you had talked about surrogacy as for those people, for other people who cannot actually carry their own children, but can a person who is infertile in some instances carry their own child? Yeah, and what are some of the solutions that that can enable them to get their own children, carry their own children? Yeah.
So before we talk the solutions, medical treatment, us as doctors, part of the solution is actually getting the problem, examining it, and then treating it. Okay? So looking at the female possible factors, we've said the males are also involved. Okay? What do we need from a man? We need a man to produce adequate sperms that are moving. And they are moving in a straight line.
Oh, so sperms can decide to move sideways?
Yes. There are those that swim in circles, and there are those that move backwards.
Okay.
So we want something called purposeful forward movement.
Focused sperms.
Yes, those are the ones we want. So the numbers have to be right and the movement has to be right. However, we have a few conditions in men that also make them unable to produce enough sperms. Okay, so you may find the sperm count is low, so it could be severely low, moderate, or mild. Okay? What we know is that for a man to be able to get a woman pregnant naturally, we need about 15 million sperms forward movement. Okay, so any discrepancy in that will give us a male factor. Okay, and the possible causes could be testicular. There are issues where you find that the testis has completely failed. It's not producing any sperms, something called azoospermia. You're producing the semen, but there's no sperm in it.
What causes that?
So the first cause is usually testicular factors. Okay, one is where you find, because the process of sperm production actually is initiated in the brain. Okay, you find the brain has done its job, it has produced the hormones, but for some reason the sperms, the testes don't respond. They don't produce the sperms.
Can it be treated?
So to some extent it can be reversible. So when someone comes in and they are what we call azoospermic, they have no sperms, we normally want to evaluate where is the problem. So the first thing we do is we run a couple of tests, and these are hormones. So there are numbers we look at. There's a hormone called FSH. The men have it, the women have it. For the men, its role is to help with sperm production. So when you run it and you find that the levels are above 12 for a man, it's going to be very hard to reverse that kind of azoospermia. Most of the time, in such cases, we go ahead and do something called testing. This is where we go straight to the testis, extract some testicular tissue, and check it to see if it has sperms. And most of the time, that couple is limited to only IVF, as we shall highlight. Okay. So From the primary testicular failure, then we have something called orchitis, mumps orchitis. Very detrimental to sperms. It will give you 0 is outside for some reason. Okay. It is outside there so that the temperature of the testis is regulated. It's regulated and it's enough for sperm production. But when you have things varicose cells are swollen blood vessels. So when they go in the testis, they accumulate blood. This blood comes with a temperature. So the temperature for sperm production becomes unfavorable. And the counts are going to go down. Or low. Or 0. Okay? And then the other part is previous surgery. Okay? Maybe a man has had maybe a herniorrhaphy done. And in the process of doing a herniorrhaphy, mistakenly, a sperm duct, the spermatic cord is cut. Okay. So things get blocked. The sperms will stay there. The semen he gives us will be empty. Okay. That's called obstructive azoospermia. The good thing with that is it can easily be treated. Yes. Okay. Yeah. And then we have a lifestyle causes in a man. Smoking is the worst case scenario. Smoking is not good for sperm production. Okay. It affects both sperm production, numbers, quality. It even affects quality of the eggs. Okay. So basically that's the male. The male evaluation is a little bit simpler compared to the female evaluation. But the problem we have is that the men hardly seek care. So most of the time you find that we start with the woman. We evaluate the woman until we find that there's nothing. And then when we insist on the partner coming in, that's when the men come in. So the men hardly seek care. And their evaluation is much simpler, but the truth is you find you're evaluating them at the end of the spectrum. Yes.
Okay. Do you find it easy for men to come in, or sometimes they have to be forced? Please go and be tested.
So it's usually not very easy for a man to come in. I think it's just the African setting. Fine, they are seeking an opinion here, they are seeking an opinion here, and the problem with the male causes is most of the time they are progressive. So you may find that your sperm count is just slightly low today. A couple of months later, you may find it completely down, totally azoospermic. So the male factors are usually a little bit progressive and no defined clear treatments. Yes.
But there is still hope for males.
There's still very good hope for males.
Okay, they can do IVF.
We can do IVF.
And do surrogacy.
Yes.
Okay. So they shouldn't lose hope.
They shouldn't.
There is hope.
There's big hope.
Okay.
Yeah.
We move on to. We have just talked about men.
So looking at basically the possible causes on both sides. Now, when an infertile couple walks in, okay, most of the time, this couple is usually stressed. Because the pressure of looking for a child and the child is not coming is really tough. So most of the time, this couple is really, really stressed. So usually us as clinicians, the first thing we want to do is to allay anxiety. Just to make them feel comfortable. Okay. So that this helps them to open up. The history they give you helps you to look at the possible cause.
Yes.
Okay. Then after taking that detailed history, they have baseline tests. Usually you want to run for this couple. Baseline tests, what we call the bare minimum tests that should at least be done. Okay. So you look on a woman's side, the bare minimum. We want a transvaginal scan. That should help us look at the uterus and also evaluate the ovaries. Okay. The next thing you want to do is a baseline, at least a hysterosalpingogram, something called an HSG. This is going to tell you about her tubal patency, if her tubes are open or blocked. The next thing you want to look at is her ovarian reserve. How much egg does she have? What is the quality of this egg? Is she ovulating on her own? Does she need help with ovulation? Or ovulation is totally impossible? So those are the baseline tests for a woman. After that, you can plan your detailed evaluation. For a man, we normally need a baseline semen analysis, even before you jump into the hormones. So a baseline semen analysis should give you a picture, and it should also guide your treatment, because this treatment for the couple can range from allaying just anxiety. Sometimes these couples are normal and it is just anxiety that is preventing them from conceiving. Anxiety and stress, they are very detrimental, especially for a woman. If a woman is anxious or she's stressed, she will not ovulate.
That's true, because I've seen when you interact with most women who are trying to conceive, most of them are stressed. Their mental state is not okay. And I think you should go deep and tell us about that, because most people are not actually conceiving because of their mental state. Every time you're going to meet someone, to meet your partner, you're like, is today the date when I'm going to conceive? Is today the time I'm going to conceive? And I agree with you that it actually affects how you like your state of conceiving. And I would like you to explain more about it, so that people can understand. Actually, it is the biggest contributing factor.
So personally, I've had couples whom I've just told, go home and relax. You will conceive. And they have actually conceived without me doing anything. That is most of the time produced by lactating mothers. Mothers who are breastfeeding. It helps in the production of breast milk. So when you're breastfeeding, this prolactin is usually very high. That's why you find that sometimes breastfeeding mothers don't even see their periods. It's because of the prolactin. But there are other cases where you find someone is not breastfeeding, but their prolactin is very high, and stress is one of the causes. So as long as your prolactin is high, you're either not going to ovulate, and at worst, you're also going to miss your period. So in that case, conceiving becomes difficult. So just allaying anxiety and everything may just be enough for this couple to conceive.
You see, why I was telling you that, I have a friend, she was trying to conceive with her husband, and it was really so hard for them. And whenever you would talk to her, every time the conversation was like, when will I get a baby? She like, every time she was like, let me go and prepare and have sex and have a baby. And she was stressed 24/7. And then the day the husband, I think the husband is so understanding. The husband told her, you know what, let's plan our wedding. They had not yet wedded. Let's plan our wedding. They started the preparations. And her mind went off the other side of conceiving. And as they were finishing the preparations before even the wedding, she had conceived. So she was no longer stressing about the conceiving, and now she got what she was. So I think most people should learn out, though it's hard not to stress.
It's hard not
to stress. But I wish we can get the way to get our minds off that stress. Thank you so much.
So usually with that we have the truth is, there's, for any couple that is trying to conceive, there's an option for each and every one. despite the cause of the infertility.
Yeah.
There is almost treatment for everything. Okay? And this treatment can range from, just like I've said, allaying anxiety, to a few interventions. Okay? So there is something called timed sexual intercourse. Okay? Timed sexual intercourse, this is something that aims for a couple to be intimate at the time when the woman is very fertile. Okay? So this involves a few series of steps. It may involve a little bit of ovulation induction with some drugs. Ovulation induction, that's where we help your ovaries to produce quite a number of eggs so that they grow, you ovulate, and by chance some get fertilized. Okay? So it's called TSI. Okay? There are couples that will benefit from that. Plain simple. There are couples that may need extra intervention, something called assisted reproductive technologies. Okay? This is where IUI and IVF come in. Okay? So what is IUI? IUI is something called intrauterine insemination. It's very close to natural conception because it doesn't involve handling of both gametes from the outside. Fertilization happens the natural way. Okay?
In the uterus.
In the uterus.
Okay.
So who benefits from IUI? Usually the people who benefit are couples where you find that there's maybe a mild male factor. The man's sperm count's a little bit low, not to achieve a natural conception, but they can do for IUI. Okay? Why would they do for IUI? Because remember, usually during intercourse, some of the semen that is deposited comes out. Okay? So IUI tends to reduce that loss.
On the leakage.
On the leakage for someone who already has a low sperm count. So we normally prepare this woman, stimulate her bit to get some good eggs. When these eggs are ready, the male spouse comes in, gives us his sperms. So we wash them. Washing them helps to make them very motile. So with the help of a simple catheter, we guide these sperms to the woman's tube, where they should meet the egg and fertilization happens.
Oh, the catheter goes to the tubes, not to the uterus.
Yes.
The egg.
So it goes to the tube.
Okay.
So you push in the sperm. Start this couple treatment for 2 weeks and do a pregnancy test later. Some couples will benefit from that. Okay? But its overall success depends on the integrity of the tube and how good your sperm is after you've washed it. Okay? The good thing with IUI, like I've said, it's close to natural conception, and in terms of cost compared to IVF,
It's cheaper.
it is relatively cheaper.
Okay.
Then there are couples that may not benefit from that. Talk of a couple with blocked tubes. They won't benefit from IUI. A couple where the man has no sperms, totally azoospermic, those won't benefit. Those ones now move on to IVF. Okay? So what is IVF? For IVF, it involves the handling of gametes, both from outside. Okay? So we stimulate the woman, we pick the eggs from the woman, then we pick the sperm from the man, fertilize these eggs individually, and get a formed baby and transfer to the woman's womb.
Okay.
Yes. A little bit of a more complex process and a little bit of a more expensive process compared to all the other interventions.
Okay.
Yes.
So those are the two only options.
So those are basically the two options in terms of assisted reproductive technologies. IUI, IVF. Yes.
Okay. Doctor, what are some of the misconceptions that are related with infertility? Most people tend to have different misconceptions. So what are some of those ones?
Okay, so a few misconceptions that couples actually come in. One is to do with is infertility, is it witchcraft related, is it hereditary related? So scientifically we haven't found a connection of infertility with African magic.
Okay.
So I cannot relate it to that. Not all the infertility cases are inherited. However, a few of the causes may be inherited. Okay? Because look at a few causes like polycystic ovarian syndrome. There's a slight bit of a genetic component in that. Okay? Look at the cases of primary ovarian failure. If someone has had their sisters that have gone into early menopause, there are very high chances that themselves too may also go into early menopause.
Okay.
So a few cases may be inherited, but not so many of them. Okay. The other misconceptions are usually with its treatment. Okay. And mostly IVF. So the misconception is these babies are being handled from outside. Are they going to be as normal as the babies that are conceived naturally? The truth is these babies are very normal. No genetic or congenital abnormalities have been associated with IVF babies. The same abnormalities that can happen in babies born naturally, the same can still happen in IVF. But it's not that IVF increases the risk. Yes. And then the other misconception is to do with family planning. Does family planning cause infertility? So we have a couple of family planning methods. We have the hormonal and we have the non-hormonal. Okay. Personally, me as a fertility specialist, when I'm counseling couples on family planning, I normally counsel them on the non-hormonal methods. Okay. Because the fact is, prolonged use of contraception, especially the hormonal methods, they may not render you infertile, but your return to fertility, even when you've stopped using them, may not be as immediate as you want it. There is usually a little bit of a delay. You find someone has used the implant for maybe 5 years, they removed the implant a year ago, and they are still not conceiving.
So the implant is hormonal?
The implant is hormonal.
So maybe if you can tell us about those ones that are some of the family planning methods that are hormonal, yes, and those that are not hormonal.
So the hormonal ones usually, you start with the simple ones, the oral combined contraceptives, and then we have the emergency pills, then we have the implants, and then we have the monthly injection, the depot, and then recently we also have the Mirena, which is the hormonal IUD. Okay. So they wouldn't ideally affect your fertility, but with prolonged use, there's likely going to be a delay in return to fertility. What I know is that if I remove my copper IUD, which is non-hormonal, someone can conceive the next day.
So there is the IUD that is hormonal,
yes,
and then there is copper IUD that is not hormonal at all.
Yes.
Okay.
So if someone has a copper IUD, even if they have had it for maybe 5-6 years, if I remove it today, someone can conceive the next day. Okay. Unlike the implant, which someone has used for a long time. However, these characteristics may vary. It also depends on how the contraceptive treats someone's body. Okay? Because there are people who use the implant and they never get to see their period until it is removed. There are those that will have the implant and still see their normal periods. There are those that will have it and actually have dysfunctional bleeding. They are bleeding on and off. So it also depends on how your body receives or reacts to the contraception.
What is this thing they usually put on the arm? I see it is like a stick.
So that's the implant.
That's the implant.
Yes. There's the implanon, which is one stick, and then there's the jadeo.
How effective are those things? Because I have a sister. She had this thing, and she conceived.
So none of the contraceptive methods are 100% effective.
Oh.
Even the IUD, which is 99% effective, there's still that small
1%
failure rate. Okay. Let's say it gets displaced. Okay. Let's say, because now with the implant, if you put it, it starts being active after a couple of days. Its activity is not immediate. So it means if you're going to rely on it, in the first few days, you will need to use backup.
So
yes, so the misconception, that's to do with basically family planning. Then the other misconception is about the success of these assisted reproductive technologies. Okay. Couples tend to think that when they come in now for these IUI, IVF, it is assured pregnancy, which is not the case. Okay. Just like natural conception, also these IUIs and IVFs have their success rates. Okay. I'm going to explain it in this way. There is something called fecundity and fecundability. Now, if you get 10 normal couples, very normal couples, and you say, let's try and conceive all of us this month, okay? Of the 10 couples, only 2 couples will conceive naturally, okay? The others are also normal.
Are all the 10 couples normal?
They are all normal.
Okay.
But the other 8 will not conceive.
Why?
It's nature. That's how nature works. Okay. So fecundability, it is the probability of achieving a pregnancy in one menstrual cycle.
Okay.
And that probability is usually about 0.1 to 0.2. Okay. So it means that if you get 10 couples and they're normal, only 2 will conceive. You may wonder, why haven't the other one conceived?
Yes.
It's nature.
Why the 2 and not the 8?
Yes. So actually, that's why we even say that we say a couple is infertile if they have gone 12 months without conceiving. This fecundability should be increasing every month. Okay. By the time you reach your 12th month, your fecundability, 90% of the couples should have conceived. Okay. So it should increase every month. That's why we say failure to conceive is after 12 months for couples that are below 35 years for a woman. Okay. Same thing with IVF. The success rates range from different units. Okay. But the success rate, usually we measure it in terms of the babies that are born following the IVF. So it can range from as low as 20% to 40%. Okay. So it means if you have 10 couples, you're doing an IVF, 2 may conceive and 8 may be negative. Or 4 may conceive and 6 may be negative. Okay. It's not 100%.
Okay.
Same thing with IUI. Yes.
IUI, I think previously I had explained what IUI is. Yeah. Okay. Doctor, I've personally visited different hospitals, fertility hospitals, and I've noticed that there are no counselors within these hospitals. And like you've said, when you're under stress, it is hard for you to conceive. Why haven't we had, like in these hospitals, people can psychologically support these people, who can emotionally support these people, your patients, so that they can prepare? Because you understand there is the kind of pressure you go through when you're going, you know, these hormones that they inject in your body and all that. There is that stress you go through. And then even when you're done with the procedure, there is that kind of pressure you go through. And then after, you know, now the terrible part is when your procedure is not successful. A doctor will just come and say, oh, you're not pregnant. Like, it's normal for him. It's normal for him to tell you, you're not pregnant. Easy for them to see a dead body, but a family member who is seeing a body for the first time, it is so hard. So I've always wondered, what's your take on the psychosocial bit of all this?
Okay.
Yeah.
So the truth is, because there's what we can do as fertility specialists, but when it comes to the counseling and psychological part, we may not handle that as well. Okay, especially in case things don't go right, and usually that's the day of the pregnancy test. Breaking that bad news for someone who has gone through all this treatment, they have spent all that money, and still the test is negative. That is very, very difficult. It is actually a very difficult process. Sometimes actually, even the doctors may not want to disclose those news. They may leave it to maybe a fertility nurse or something to break the news to the patient. So it's really, really difficult, especially for couples that don't conceive. I've had great successes, but I've also had failures. I've had couples that have cried in my office and broken down, and you may not really address that part very well. So in cases where you find there's no psychologist on site, personally, I've referred these people to a psychologist on the outside, even before thinking of the next step, whether to do another cycle or to first give it a break or to do what. At least an interaction with the cancer, because there's much more they can do. For us, we are invested in the science. We may not address the emotional part. So the truth is, every fertility center needs a psychologist.
They do
need a psychologist, but it's for the starters. Initially there was really, really none, but at least now in some centers I'm sure there's someone that sits there and just addresses that.
You see why I asked you that? Personally, I did an IUI. Yes, I did it from a certain fertility hospital, and the way I was given the news that you're actually not pregnant, it was heartbreaking. Someone goes through your paper and says, you're not pregnant. I'm like, does this sound so normal for you, like that I'm not actually pregnant? And she's like, so the solution is we can actually continue and do the next cycle. Actually, you can even go for IVF. And most people actually don't have it's the costs are high. They are very high, and when they are talking to you, they leave out that factor. They leave out that factor. They just think it is easy. I think they have dealt so much with people who are in that situation, in that it is so easy for them to deliver that news. And actually, I've told you about my foundation, and I think that's one thing that necessitated me to start a foundation where we can psychologically prepare these people for the procedures and the outcomes, and even those who have gone through the roles. Even like if you interact with people who have gone through the roles, you've carried your baby for a month or two, and you've lost them, and you know you've struggled to get these babies. You know, you look at them like no one is stable. No one is mentally stable. They need to talk to someone. So actually, that's basically the reason I started this foundation. And I hope it is going to help most of these women. I should address the psychosocial bit of it. And we are actually ready to, you know, to talk to these women, prepare them. If you're going through a procedure, you come and you talk to a psychotherapist, and we hope that it will actually, we hope as a foundation, we hope that it is going to prepare them mentally, be ready for anything that comes, and maybe we shall reduce on the anxieties and all that.
So thank you everyone that has tuned in to listen to us. Thank you, Prosi, for hosting us. The truth is, infertility is here with us, and it is common. Actually, about 10 to 15% of couples are going to struggle with infertility. But the good news is there is a solution for every form of infertility. And this solution can range from simple stimulation to the extensive assisted reproductive technologies. Personally, I feel that every couple with a desire to have a child, with the current technology, they should be able to have a child. So if you're out there and still struggling, don't give up. Something is going to happen your way. The only thing you need to do is seek care, get diagnosed, get the right diagnosis, because that is going to determine the form of treatment you get. But you will surely conceive. Thank you.
Thank you so much, Dr. Mhumza. We were so happy to have you here, and thank you for explaining in detail everything. I hope we have learned. Most people have learned from your discussion. Until next time, and we hope we are going to have you here more and more to explain to our people exactly what is going on. Thank you so much for watching us. It's been surely an educative session. Don't forget to subscribe, like, and comment. Until next time, bye.